Hospital of Queens. He is terrific. And again, I know this not from personal experience, but from patient experience. And he does bariatric surgery, and one of the things you have to do when you're a bariatric surgeon is to be able to say no, because sometimes you're not suited for it. But he's going to tell you who is suited and the different approaches that we have to it. And just turn the mic over.
Thanks, Dr. Bright. Thank you for having me. So I'm going to go, I gave a talk last year. I kind of updated it a bit. Basically, as I said, this is a devastating complication that we're experiencing in the United States in terms of the prevalence of obesity. And I'll kind of show you the most recent data on the obesity rates in the United States. Review the rationale, which patients or which individuals should think of an operation. Now, if you aren't able to lose that weight and you are dangerously heavy and having complications from it, specifically diabetes or high blood pressure or sleep apnea, those are the patients that might want to consider weight loss operations. Talking about the current status of the lap band, talking outside, it's kind of fallen out of favor in most centers. We can talk about why. Review the two other operations that are currently out there that people are having, and then kind of tell you about just a possibility of what may come down in the future. It may or may not, but I'll show you a little bit more detail. So the three red ones are kind of the things I've updated since a year ago. As far as the prevalence of obesity, this is the United States. Actually, I think I had data going back into the 80s. 1990s, every state's reporting out their obesity rates. And so as far as what percentage are obese, we're down in this blue area or down here. 10%, the light blue, less than 10% actually, 10 to 14% for the darker blue, like Missouri and stuff like that, or the 15 to 19% range. You kind of look at it over 3 decades. In the 2000s, a lot more were in this range. And now, 2010, most are in this range and this range. And that's only in 20 years. It went from almost tripling in the obesity rates in the United States in a very short period of time. This is the very most recent from the Centers for Disease Control, 2013. Mississippi and West Virginia impressively are over 35% obese now. That's meaning at least 30 pounds over their ideal body weight, an individual at least that heavy. Even Colorado was a holdout. Colorado for years was always less than 20%, and now they're up to 20-25%. Even Colorado, which held out for literally like a decade, and suddenly their obesity rates are rising in Colorado. There's not a state in the union that is not experiencing severe epidemic of obesity. I usually tell people about 1/3 of the U.S. population on average is obese now. About a third of the U.S. population is overweight at this point, and only about 1/3 of the U.S. population is at their ideal body weight. This is clearly the biggest healthcare epidemic the country's ever faced. Bigger than HIV, bigger than, it's affecting 1 in 3 people. I think at the rate we're going, it's going to affect almost 4 out of 10 people. I think at the rate we're going, I go to 2020, I think we're going to be reaching obesity rates pushing 40% in this country. As far as your weight, what you need to know is you do need to know your body mass index. It's important because you have a certain height, certain weight, and you're like, well, I think it's crazy. So what we use in medicine in general, but definitely in obesity surgeries, we look at your body mass index. It's your weight in kilograms divided by your height in meters squared. You can Google tons of applications and the BMI calculators to figure out what that is. Ideally, your BMI should be in this lower range, 18 to 25. That's considered healthy. As I said, that's only about 1/3 of Americans at this point. BMI over 25 is considered overweight, so 25 to 30 is an overweight range. That's about 1/3 of the U.S. population. And then the final 1/3 of the U.S. is 30 and higher. So in that map I was showing you, that was people with BMIs of at least 30 or higher in that state. People start thinking about surgery, getting that severely obese or morbidly obese. Morbidly just means it's dangerous to your health. That's the 40+ range and the 50, 60. I believe, seeing yesterday, I think it was reached a BMI of 75 or 80 actually, coming to my office tomorrow. Why is this a problem? Well, in the state of New York, 59% of people have a BMI over 25, the majority. 56% in Queens are overweight or obese, and that corresponds with about obesity of diabetes rates of almost 10%. 9% in New York State, and in Queens alone, we have 11% diabetes rate. 1 in 10 people walking around with diabetes. I always marvel. I put this slide in last year. I always marvel this because it's 1.26 million people are overweight in Queens. And there's 250,000 diabetes. You know, it's bigger than most cities. 250,000 people in Queens have diabetes. And as far as the risks, your type 2 diabetes, high blood pressure, coronary disease, and stroke, and if your BMI is less than 25, your risk of getting those is going to be low. It's going to be equal to whatever your genetic risk would be. But as your BMI starts to climb up, and you get that BMI over 35, which is right in the middle of the obese range, your risk of diabetes goes up 6-fold. High blood pressure almost quadruples, and heart disease and stroke go up. But in addition to that, I'll get to that side in a second. Obesity is clearly the #2 cause of preventable death in the United States. The only thing that's still probably killing more people than obesity is still cigarette smoking. Cigarettes are just bad. I had a patient the other day came to see me and wanted obesity surgery and they were smoking. And I said, well, you're going to, unfortunately pass away just as young because your cigarettes are going to kill you. But they're both, bad to have. But obesity is fast approaching, probably to overtake smoking as the #1 cause of death in the United States. That's considered preventable. In comparison, the number of people dying in automobile accidents every year in this country is 40,000 people. We're having probably 10-fold that many people dying from cigarettes and obesity, or actually 20-fold that. These are the complications that people with obesity start to experience when that BMI starts getting up in the 30s and 40s. People don't realize the risk of cancer is elevated with obesity, more likely to get ovarian cancer, colon cancer. Heart disease clearly up if because of the risk of diabetes. Gallbladder disease, a lot more patients. I also do bariatric surgery. I also do, I took out 3 patients' gallbladders earlier today. I do gallbladder surgery. 2 out of 3 were obese. Obesity definitely is a risk factor for gallbladder disease. High blood pressure, a good number of adults with high blood pressure also are obese. And these are some of the other ones that people don't realize, birth defects and daytime sleepiness. Gout is even related to obesity. I have to give you 2 slides of this actually. Infertility in women. Heavier women sometimes have irregular menses. They don't know when they're ovulating. I have women BMI 60, 70 who don't ovulate. They don't have periods basically because of their weight. And then sleep apnea. I find sleep apnea, it's amazingly underdiagnosed. I have so many people come to see me who could weigh 300 pounds or 350 pounds. Clearly have sleep apnea and no one's ever actually investigated it. And it's as deadly as diabetes or high blood pressure. I was talking to our chief of anesthesia once, a few months ago, and I said, what's worse, sleep apnea or diabetes? He said, sleep apnea by far is much worse than diabetes. Because if you have diabetes, at least if you control it, and you have a well-controlled diabetic, that's much safer than having somebody coming into an operating room with obstructive sleep apnea. And for those who are not familiar with sleep apnea it's as you get heavier, you don't have to be heavy. Most people with sleep apnea are heavier. When you're heavier, what happens is you have extra tissue in your throat. And so when you get in that deep, relaxing sleep, that level 4, REM sleep that's really supposed to give you the rest you need, what happens is your airway relaxes and it blocks your airway. And as it's blocked, there's a little bit of resistance to your breathing. That's where people will snore. When you get completely obstructed and no air is moving whatsoever, most people will wake up. You cough and choke and you wake up. The problem is that you fall, you go into that deep sleep. You never really get to that deep sleep because as soon as you get there, you wake up because you get obstructed. And then you go back to sleep again. You get to the deep sleep again, and it happens all over again. So patients with sleep apnea wake up all night long getting obstructed with sleep apnea, and the problem is they get a horrible night's sleep, which, again, isn't good for weight loss. Isn't good for your job. I mean, people fall asleep at work. And the other big thing people don't realize, sleep apnea is a leading cause of car accidents. People, fall asleep behind the wheel. I had a guy once who came up to me after one of my seminars I give for patients thinking about surgery, and he said, that's what I have that exactly. He goes, it's so bad I went to see an ENT doctor, he told me not to drive anymore, because what he would do is when he got to the lights, he would actually have to stop, he'd have to put it in park, because he would fall asleep at the light, every light he would hit. And then when somebody hung behind him, he would, wake up and go. The doctor's like, don't drive anymore. Now there's treatments for it. People have what's called BiPAP or CPAP machines. They give you positive pressure to mask your air and forces air into your airway to keep it open so that the air exchanges better and your air doesn't get obstructed. Clearly, the best weight loss for most of those patients is weight loss. The best treatment is to lose weight. Again, risk of stroke or even surgical complications. It's far easier. Again, I do a lot of bariatric surgery, but I'm also a general surgeon. Whether it's a hernia or gallbladder or taking out somebody's colon for cancer, it's clearly much easier and safer to operate on a thinner patient than it is on a heavy patient. As far as weight loss options, people try diets. Probably aren't any miracle diets. You kind of have to do what Izzo kind of talked about. That's you have to have a habit and form habits. To go suddenly on the Atkins diet, is a great thing. But you do the Atkins diet and suddenly you do all that protein and fat and avoid all carbs basically. Most people can only last a certain amount of time. After about a month or two, you suddenly wake up one day and you go, I love bread. Bread is good. And as soon as you start eating bread, people on the Atkins diet will talk about how the weight kind of just comes right back again. So in studies, the average person will last on Atkins about 2 months. Not to mention the high cholesterol and all that stuff. But after about 2 months, people stop it and they go back to eat. So there's really been no miracle diet. You can increase your level of physical activity. For a lot of my patients, it's a hard thing to do. If you're 300 pounds on average, which is the patients I see, it's very hard to suddenly increase exercise. They get winded. It's difficult for them, especially if you're trying to lose a significant amount of weight. You can try to do your behavioral modification. Again, we're talking about the person who's a bit overweight. We're talking about people with BMIs of 50 or 40, 48. It's hard to make that modification. And there really hasn't been any medications. All these years, there's never been any. The only drug that ever seemed to work to some degree that, people come to me and I'll say, what was your most success? The number one drug I've heard was fen-phen. But fen-phen came off the market because of cardiac complications. But I had some men who would say, oh, it's 100 pounds on fen-phen. And when I couldn't get it anymore, I gained all the weight and I've been heavy ever since. But short of fen-phen, there's really nothing left on the market. There's Ally, which you see at the supermarket. The problem with Ally, it's a drug that was actually called Xenical. It's FDA approved now over the counter. It's a drug that makes you not absorb fat. So basically you take the pill before your meal, and if you eat a big fatty meal, you kind of pay for it a little bit. You get cramps, you get loose stool, you get diarrhea. And the weight loss is modest. And on top of it, most people in studies, as soon as they get, the runs from what they ate, they stop taking the, you're not going to keep taking Ally if you're going to get the runs. And in one study, the number one reason people stopped it was the runs were so bad that it would leak a little bit in their underwear. And obviously at that point, people would stop taking the drug. So there really, unfortunately, hasn't been any medications out there. And they always talk about this new drug coming here and there, but nothing really is out. Nothing really at this point on the horizon to bring significant weight loss for the patients that I see, basically. So we're going to kind of talk about the operations. Just so you know, people are always interested about obesity surgery, even if they're not eligible. They want to kind of know, well, what's that all about? And you hear so much about it in the news. So, I'm going to kind of go through the operations with you, what the eligibility requirements are, what my takes are on the operations that are out there, and then in the end, obviously, if you have any other questions about obesity surgery, feel free. So, 1991, the National Institute of Health, which is our government agency that funds more medical research than any agency in the world, actually, and every medical school is trying to get, how many NIH grants we can get. Well, the NIH in 1991 had a consensus statement, or conference actually, where they brought together nutritionists and physicians and surgeons and nutritionists and endocrinologists and psychiatrists, and said, okay, we need to make a recommendation. There's this operation out there where we could help somebody who's severely obese lose weight and improve their life expectancy, because men can die 10, 15, 20 years younger due to obesity, and women maybe 8 or 10 years younger from being severely obese. So we need to, then we have an operation that we can improve their lifespan, treat their diabetes, treat their high blood pressure, treat their sleep apnea, but who should have the operation? It can't be a subjective thing like, I really would like to lose some weight, I'd like to have an operation. It had to be for people who were really at danger if they maintain that weight, and had to decide who should be offered that operation. They really felt that, and this is true, is that if you go on a diet, weight reduction with or without behavioral modification of drugs had an unacceptably high instance of regaining of the weight within 2 years of maximal weight loss. So I always have to read this like 6 times to make sense of it. But basically what they said was, if you go on a diet right now, in January 2015, and by October you lost 50 pounds and feel great. That's October 2015. By October 2017, 90-some-odd% of people would have gained all the weight back again. So you kind of always care, and I always tell patients this, you kind of care how much weight you're going to lose, but more importantly, you care that you're going to keep the weight off. No sense going through a diet or an operation and losing 60 or 70 pounds when a year later or 2 years later, you gain all the weight back. So they felt that for many patients, despite drugs or behavioral modification, diets and things like that, the majority of them within 2 years gained all the weight back again. and they were still, again, having that BMI of 40 or 50 or 60 and in a danger of complications, or living with complications of obesity. So what the NIH did in 91, there's a little background which I'll tell you about in a second, but what the NIH did in 91 was they came up with a recommendation. They basically said you had to be well informed. That's why most centers, including Dr. Castro and New York Hospital Queens, we do a seminar every month where we educate patients before surgery to kind of go through all the details of the operation. So the patients are well informed. I always tell patients that I operate on for obesity surgery are much better informed than any other patient having surgery. Much better informed than the patient whose gallbladder I take out or the colon I take out. They go through an hour seminar, they get a booklet, they meet a nutritionist, they meet a psychiatrist. I actually give them a quiz before surgery. So they're well informed. They have to be motivated. I think if you're going to go have an obesity operation, you're pretty motivated because it's a little scary. You know, I'm a pretty nice guy, but I'm scary. You know, I do have a knife and I do cut people. And so to actually come to a surgeon and actually come to that seminar or come to our office to see us takes a lot of courage. I think most people putting it off coming to see a surgeon for obesity a long time. So by the time they come, they're definitely motivated. So you have to be well informed, you have to be well motivated, and you have to try to lose weight. Now, it doesn't have to always be formal. You can't say, well, you know, I did the Weight Watchers for 6 months or I did Nutrisystem. But you have to be honest. You have to be honest with me, you have to be honest with the nutritionist, you have to be honest with yourself that, you know, that you've really tried. So, you know, if somebody's tried, you know, 6 or 7 diets, you know, whether it's formal, informal, or both, you know, I always tell people, why do you think diet number 8 is going to work for you? You know, you've been heavy for many people for 20, 30 years. You've tried 6 or 7 diets. The odds of diet number 7, number 8 not working. Now, that's different than somebody who says, well, you know, I joined a gym and I never really win. You know, and I tried to eat a little healthier, you know, some salads, but, you know, it only last a couple of days. Now I would like to have my, you know, stomach surgery. That's not a candidate. But if you can honestly say, you know, I really worked at it, I really tried over the last 5 or 6 years, and the rules actually are you have to try to lose weight for about 5 years. So that's the background. You have to be well-informed, motivated, you have to try to lose weight. And then lastly, you have to have a certain weight requirement. And again, we don't talk about weights, we talk about body mass index, we talk about BMI. So they used to cut off a BMI of 40 because they felt that if your BMI was over 40, that the risk of this was greater than the risk of any complications from surgery. Although there's risk of complications from surgeries, which we can touch on, the issue was that if your BMI was 40 or definitely 50, it was thought that you're more likely to have a complication or die young actually from living with that BMI that high than you were from the risk of having an operation. Now I always tell people the risk of the operation is always going to be scarier, however, because with the risk of the operation, you're going to bundle all that risk up and face it head on one day, the day you show up for an operation. That's scary. Because you're going to have a bad complication, it's going to be in that first couple of days. And so you're facing all that risk head on. The risk of your obesity, although greater if your BMI is over 40 than an operation, you can stretch it out a bit. You know, you're not going to go home tonight and drop dead from obesity, or tomorrow, or next week, or 3 months from now. You know, it can take years before you get all the complications of diabetes and needing a stent in your heart. So it's humans just procrastinate a bit. But again, the argument was that if your BMI was over 40, the risk of surgery was less than the risk of you living with that weight. Or if you have BMI over 35 and you're already having complications of obesity, namely diabetes, high blood pressure, or again, obstructive sleep apnea. If you have those complications, obesity is getting so bad it's already hurting you, then the thought was that if your BMI is over 35 and you have those complications, you're better off having an operation than living with your obesity. It was safer, actually, to have an operation. Now, the interesting thing about this is 1991. This is 20 years ago. And the operation that was done in 1991 that this is based on, as far as risk-benefit, is an open gastric bypass. Now, an open gastric bypass is definitely a riskier operation than a laparoscopic bypass, and a lot riskier than a laparoscopic sleeve gastrectomy or a laparoscopic band. So you would think that, well, if the operations gets, you know, less risky, these numbers actually should come down a little bit. They've sat there now for 20 years. People keep talking about having another consensus and changing the numbers. The number one reason they don't change is the healthcare lobby. The healthcare company, the health insurance doesn't want to change it because, you know, the number of people who are obese is a bell-shaped curve. And if you shift the curve, the BMI cut off a little bit to the left, it's a large area under the curve. It becomes a large number of patients. You know, they already don't want to, you know, I'm not getting into it, but getting people certified for obesity surgery is a bit of a challenge to begin with in insurance companies. They're not opening their arms saying, let's, you know, we're going to help you out and have an operation. To lower the BMI cutoff and increase the number of people eligible, they don't want that right now. So this is the criteria that I use, that other centers use. It's also the criteria insurance companies use, because insurance companies do cover it. But again, only if you meet this criteria. somebody in the audience probably thinking, well, why would an insurance company want to, pay for this operation, make me healthier, cost less money? But the reality is that in the United States, the average person changes insurance every 18 to 19 months. And the break-even point for this operation in terms of savings versus what it costs is probably around 6 or 7 years. So if they do the math, it takes them 6 or 7 years to break even, but the majority of people would change to a different insurance company. So they don't break even, they actually lose money. It's just the way the healthcare system is set up. So we're going to talk about operations. That's the last thing we're going to get into. And then we'll actually talk about something that may come down the pipeline, may or may not. So obesity surgery started in the 1950s, actually. The first operation, the juno-ileo bypass, unfortunately is the operation that gave bypass surgery or gastric surgery in general for obesity a bad name. It was a bypass that didn't bypass most of the intestines, and patients had severe malnutrition. Some had liver problems, needed liver transplants. Back then they probably didn't have liver transplants, but liver failure basically. And so that operation isn't done anymore. But in 1967, a guy named Mason in Iowa actually said, well, when people have their stomach removed for cancer, they get very skinny. And he said, well, what about the 250-pound, 260-pound woman or a 300-pound man? What if we did an operation somewhat like that and removed a good portion of their stomach? Would that help them with weight loss? So he created the gastric bypass in the late 60s. That became one of the #1 operations up until the 1980s. In the 1980s, another operation came along called the vertical banded gastroplasty. That was very popular for about 10 or 15 years. However, after about 10 years of follow-up, people realized that a lot of those patients started putting weight back on. And so vertical banded gastroplasty, or it's called VBG, fell out of favor by the turn of the millennium. It's not really done at all in the United States anymore, although it's still in Europe some. The most common reason I see VBGs is people having either complications or not having lost weight and wanting me to convert them to a gastric bypass. Bilipancreatic diversion, duodenal switch, operation done in the early 90s. Also fell out of favor in the United States because it's a pretty distal bypass, similar to this operation. And so patients would have a lot of problems. For example, vitamin D deficiencies, they would break bones bending over to tie their shoelaces. Vitamin A deficiencies where they have trouble seeing. So, although a lot of people advocate this for what's called the super obese, BMI 60 and up higher, thinking that this is going to get them a better result than a bypass or a sleeve gastrectomy. But again, in the United States, it's kind of fallen out of favor. A laparoscopic bypass was done first over 20 years ago now in San Diego by Dr. Whitgrove. And that really opened up bariatric surgery or obesity surgery. But up until then, it wasn't a huge field. And I think what happened is it was the technology of laparoscopy. More and more surgeons, very skilled surgeons got involved in the profession, and obviously the obesity rate went through the roof in the United States. So by the late 90s, early 2000s, I trained in around 2000. Laparoscopic bypass was the #1 operation in the United States. It was extremely popular. Interestingly, then in 2001, the FDA approved the lap band. It had been being done previously already in Europe, Australia, and Israel, but not in the United States until 2001. Excuse me. 2001, they approved the lap band. The lap band quickly became the #1 operation in the United States for a couple reasons, which we'll talk about. The lap band was safer. It was the safest of all the options out there, so people liked the safety profile of it. In addition, it was also very popular because the company did a very good job marketing the lap band. The problem with it, and we'll talk about it, is that the outcomes were not quite as good as the other operations. The gold standard operation that actually people compare to see how good an operation is the gastric bypass. That's our gold standard. So whenever we compare new operations, we say how much weight loss is it compared to a bypass, and we'll talk about that. And then in 2004, the sleeve gastrectomy came about. 2004, it came about as an interesting way. Around that time, the men that were really heavy, like 400, 500 pounds, would come in and they'd go have laparoscopic gastric bypass. At the time, the mortality rate for gastric bypass in the United States was 0.5%. 1 in 200 people died from a gastric bypass. The mortality rate for a 450-pound man with sleep apnea was almost 10%. In Maimonides, they published about 10%, Hackensack, New Jersey, about a 15% rate. Now these guys would say, look, I'm 500 pounds, I'm desperate. 1 out of 10 chance of dying doesn't sound so bad, I'll take it. But as a surgeon, where your risk of a patient dying on you is 20 times higher, the surgeons were not obviously happy about it. And so what happened was, around 2004, a surgeon realized, well, what if we do something called a sleeve gastrectomy, which I'll show you, which is removing about 70% of the stomach. And these patients would drop from 450, 500 pounds, maybe down to 300. kind of similar weight as the average person having that gastric bypass surgery. And then they would go back in and they would convert, or do a second operation and convert the sleeve into a laparoscopic bypass in 2 stages. But the thought was when you're doing that bypass on that patient, who's now instead of being 500 was 320, and maybe with a BMI of 45 instead of 65, that their operative risk would be, or chance of dying from that operation would be 0.5%, same as everybody else. And that's what happened. So it became very popular where people would do a sleeve gastrectomy on these really heavy people with the plan of doing a bypass later to lower the operative risk. But it was 2 operations, but otherwise it worked very well. Interestingly, 2 out of 3 people who got a sleeve gastrectomy never came for the second operation. Because they lost so much weight with the sleeve, they were like, I'm happy with the sleeve, why would I take a risk of a bypass? And so finally, around 2008, a lot of people started saying, well, what if we just stop offering this operation solely to the 400-pound, 500-pound man or woman? But why don't we just offer it to anybody who's eligible? Anybody with a BMI of 40 or higher, anybody with a BMI of 35 with diabetes or high blood pressure. If it works really well for those patients with a 60 BMI, it should work really well for a person with a BMI of, say, 44. And that's what happened. Around 2008, the sleeve gastrectomy got very popular as a single-stage operation. Only one operation, that's it. And so the 3 operations became bypass, sleeve, and band. And what's happened in the last couple of years is a lot of that shifted a lot. Sleeve gastrectomy has now become the #1 operation, while bands went down, because I think a lot of people saw complications with the band, either inadequate weight loss or band erosions, or the band just moving out of position, having to be taken out, while the sleeve gastrectomy has a safety profile much closer to a lap band, safer than a bypass, but with weight loss, much closer to a bypass. So you have an operation that's closer to safety to a lap band, but gets you weight loss closer to a bypass, and that's why sleeves become very popular. So the 2 operations that we offer now are sleeve and bypass at Queens. Dr. Castro and I made a conscious effort, maybe, I would say 6 months ago, we don't even have lap bands anymore. I still have lots of patients I put lap bands in, I still adjust them, things like that. But for those not familiar, maybe not everybody knows what a lap band is. A lap band was a silastic rubber tubing that was placed around the stomach. So basically, this is the lap band. It was placed around the stomach, 360, with a tube going out to the skin, to a little port, kind of like a chemotherapy port that you could feel under the skin. And this band was hard plastic, but inside the inner lining of that was a balloon, and it could be filled up with saline or water, basically. And so food would come down to here, and if the band was wide open, meaning it had nothing in it, food would go through pretty easily. But if somebody was eating too much food, you could actually, in the office, I could prep their skin, feel that little port, stick a needle in it, inject some saline, blow up that balloon, and the opening between here and here would get tighter. And so food wouldn't get through so easily. So the food would get stuck up on here, and that area of the stomach would get stretched out, and people would feel satisfied. They would eat less food because they feel full. That's how the band was supposed to work, and that's kind of how it does work. And then what would happen is, every month for a year or so, patients would come to my office, and if they say to me, look, I look at see how much weight they lost. If they didn't lose any weight, and they said, I can eat a fair amount, I would give them a little bit more fluid, and they get a little bit tighter, and come back a month and do it all over again. And I really was trying to get, with all my operations, I'm trying to get people to get satisfied on about a half a sandwich. It doesn't have to be sandwich. Not everybody, wants bread or whatever. But, if I tell them if I gave you, 2 slices of bread and something inside, and I asked you to eat it, how much could you eat? And they would say, if a half a sandwich made them full. And if they came to me and said, I could eat a whole sandwich, and I'm still hungry, and I'm not losing weight, obviously, or I gained 2 pounds, I would tighten them some more. If they came back and said, look, about a half a sandwich, 3/4 a sandwich, I'm full, and I look at the scale, and they lost maybe 1 or 2 pounds a week over the last month, so maybe 4 or 5 pounds that month, and they feel tighter, I would leave them be. And so the consequence is that, again, the weight loss goal for a band was like 1 pound or 2 a week, and so it would take a while to lose the weight. It could take 2 or 3 years. The problem with banding was a couple-fold. One was that about half the patients didn't lose a lot of weight. So people always know people with bands that just never really seemed to lose the weight, and half did. And I was at a meeting once, a bariatric surgery conference, and a guy from Italy got up and he said, he was on the panel actually, and he said, the issue about lap bands is they work well for about 50% of people, they don't work well for about 50% of people, but you don't know going in which 50% you're going to be in. So the problem is you have an operation that only worked on about half the people, and you don't know going in whether you're going to be the good half or the bad half. The other problem with the lap band is that complications. Either the band moved out of position, or the band eroded into the stomach, actually. I've actually done it, unfortunately none of my patients, but over last year I had 3 patients, one who had a band put in Israel, one who had put it done at Columbia University, and one got put in, North Shore Forest Hills. And they had pain when they did an endoscopy and looked inside the stomach, they could actually see this white band on the inside of the stomach. The pressure of the band on the stomach, it eroded through the wall of the stomach and actually inside the stomach. So I had to take those bands out for those patients. So the band erosion is a complication. The band can slip where the stomach herniates up through the band, and the band gets tilted and obstructs the patient. The band often has to be taken out. And so in one study recently, within 5 years was it 4 years or 5 years of lap band placement, about 70% of people had a problem with their band. If you counted inadequate weight loss, coupled with complications, about 70% of people within 5 years had the band removed. So the issue with the band is it didn't become a good operation except for a small percentage of people. So we're doing an operation on somebody where the majority of people wouldn't do well. The company, Allergan, who makes Botox, actually within the last year sold off the company, lap band company, to another company because they realized the end was near. So the number of lap bands being put in the United States, plummeted. Most centers in the area actually stopped doing lap bands. And I always tell people always want to know what operations I do. I go, number 1 operation I do right now is sleeve gastrectomy. Number 2 is gastric bypass. Third most common operation I do is take out lap bands, actually. And interestingly, it's amazing. If you look at Europe in the 90s, they were putting a lot of lap bands in. By the early 2000s, they were taking them out. In the United States, we suddenly started putting more in. For some reason, we just ignored what was happening on the other side of the Atlantic Ocean. And then, obviously 10 years later, we're doing what Europe was doing, which was taking bands out. But in the early 2000s, the number 1 operation related to bands in Europe was taking them out, not putting them in. But we were just, putting a lot in. And I will tell you another thing about that. Surgeons, impugn the surgeons a little bit. Patients liked it, but surgeons did too. Lap bands are very easy to do. I put in lap bands that are easier than taking out some people's gallbladders. And surgeons could do, and the bypass can take 3 hours. The band could take under an hour. And the patients went home the same day, didn't stay in the hospital. So you had nobody, So you could do 3 or 4 bands in the time it takes you to do 1 bypass. And the complication was very low. So the surgeons liked it as well. The problem is that 5 years later, 10 years later, we realized the majority of patients weren't doing well. So that's why lap bands kind of fell out of favor, and why most, when I talk to most of the colleagues in the area, most places don't do lap bands anymore. The only places still doing lap bands are the places that were like doing only lap bands. Now even those centers are trying to do sleeve gastrectomies, but they still offer the band. So the 2 things we're going to talk about, sleeve gastrectomy. Most of my talks I have bypass first because it's the oldest, but I put sleeve first now because it's definitely the most popular. So what a sleeve gastrectomy is this is your esophagus, your stomach, your pancreas, your gallbladder, and your intestines go this way. In this grayed out area, your stomach normally would be this big. But when I do a sleeve gastrectomy, what I do, and I do these laparoscopically through 5 small incisions. My partner and I did, 3 just between yesterday and today. Is we go about 4 centimeters from the pylorus, which is the valve right here that ends the stomach, right to there. And then we take a stapler, and we staple all the way up to here. We actually take all that stomach out. We remove that part of the stomach, about 70% of the stomach. It leaves just a tube of stomach, or I tell people like a banana, basically. It's like the shape of a banana, the size of a banana, actually. It's called a sleeve because we put a special tube in the stomach when we staple it, so we don't staple the wrong direction and staple across it. And it's called a sleeve because it's the way the tailor makes your sleeve. And so in the end, we take out that part of the stomach. If your stomach's the size of a banana, you're not going to be able to eat as much. This part of the stomach, the lesser curve, it's called, never really stretches. The part that really stretches is this part. It's called the greater curve. It really can stretch quite tremendously. And so we take that out, that stretchable part, and leave just a staple line. The staple line doesn't stretch very much. So you've got a banana-sized stomach that doesn't stretch very wide. So patients dramatically eat less. Again, with my question about a sandwich, it's usually a half a sandwich. They eat about half a sandwich and they feel full. The weight loss can be very dramatic. I had one guy, I have a picture in my office, he was 550 when I met him, he's down to 250 now after sleeve gastrectomy. And some weight loss on his own. He lost close to 100 pounds on his own pre-op to get down to a safer weight, and then he lost well over 100 pounds with the sleeve gastrectomy. And so the issue about the sleeve gastrectomy is patients lose weight very rapidly because they can't eat as much. And nobody realized this, but the fundus, which is this part of the stomach here, controls glucose metabolism, controls appetite, a hormone called ghrelin. And so people didn't realize this. They really thought that the sleeve was just a restrictive operation, kind of like a lap band or the old vertical banded gastroplasty I mentioned. And then people started doing studies and realized that actually the operation is also metabolic. Removing that part of the stomach has an effect on glucose metabolism, has an effect on diabetes. So it's not just purely a restrictive operation, it's restrictive, and the removal of the stomach has some effect on the metabolics of the patient. And that's why the operation works so well. I usually tell people the weight loss is as rapid as a bypass, usually within 12 months. And the weight loss is fairly close to bypass, but can be about 10 pounds less. And I think it's popular because people say, well, if I'm going to lose 10 pounds or 10% less weight with a sleeve versus a bypass, but the complication rate of a sleeve is half of a bypass, that's why people choose a sleeve. They pick an operation where half the risk of complications and almost comparable weight loss. Now the bypass is an interesting operation. So this is what Dr. Mason kind of invented. It's modified a little bit. This is what the laparoscopic bypass looks like. But basically, food comes down your esophagus into your stomach. This is your, if you remember the other picture, this is your whole stomach. In the bypass, I actually divide the stomach into a small little upper stomach. That's about the size of a large egg. Again, probably, maybe a third of the size of that banana. Banana maybe 3 times that stomach in terms of size. So either way, it's small. But it's definitely, this is the smaller of the two. The egg-sized stomach. Since I completely divide the stomach, I have to reconnect the intestines. So I go down here, I divide the intestines, and I bring a loop all the way up and reconnect it here. And then I have to reconnect it down here as well. And this, it's called a roux and Y. You have to see the Y. This is called the roux limb. And basically, food will come down here, go into that large egg-sized stomach. It'll get stretched, just like with the lap band or with the sleeve. When it gets stretched, it releases hormones that tell you you're satisfied, you're full, basically. And it's amazing. It's this little part gets full, and you feel full, even though you have all this other stomach. Then the food will go down the intestines this way. You lose weight with a bypass for 2 reasons. As I was saying, we were surprised to find out that a sleeve was a combined procedure, had a restrictive component and a metabolic effect. The bypass has always been the classic combined procedure. It has a restrictive component, your stomach can't take as much, but it also has an interesting metabolic effect. How this works is that foods come down this way, but the acid from your stomach is in here, your pancreas plugs in over here, your bile from your liver plugs in here, so all your digestive juices are going down this way, while your food's going down that way. So the food going down here hasn't seen any digestive juices other than some saliva. And so the food's not broken down to its basic sugar, basic protein, basic fat. So while the food's running through here, you can't absorb any of that. You don't absorb any of that fat, protein, calories, or vitamins until the food gets down here. Because you do need to absorb that stuff. So when the food gets down to here, it mixes with the digestive juices and digestion occurs. And then for the remainder of the patient's intestines, they absorb the fat, calories, the protein, and nutrition they need. My typical bypasses, I usually bypass about 1/3 of the intestines. So patients, if they eat 300 calories, they may only absorb 200 calories. So they absorb less food, and they're obviously eating less food. So the bypass works by, again, eating very small amounts and not absorbing all your calories, basically. And that's why the weight loss for a bypass is also fairly dramatic. This is typical weight loss. This is for a bypass, and the sleeve's pretty close. This is our experience with a bypass. So within a year, most people lose 75% of their excess body weight. So I always use 100 because it's easy math. If you're 100 pounds overweight, you lose 75.6 pounds. And by year 2, you can lose. By a year and a half, you lose 80 pounds basically. And so I usually tell people with a bypass, you're going to lose about 70–80% of their excess body weight within about a year. Sleeves, I usually might say 65–70%, a little less, maybe 60–70%, while a bypass is probably 70–80%, about a 10% difference. Both very good, obviously. Because with that weight loss, most of the medical complications get better. The big question people always have with this is, well, how long do they keep it off? The reason why the bypass has been around for all these years, since the 60s, is actually that following these patients out 10–15 years later after bypass surgery, they keep the weight off, basically. The majority, about 80+% of people, will keep at least 50% of their excess body weight off the rest of their life. We use 50% as a cutoff for success. So again, if you're 100 pounds overweight, keeping at least 50 pounds the rest of your life off. If you're 150 pounds overweight, keeping at least 75 pounds off the rest. The majority of patients with the bypass do. It's interesting, when bands came around, a lot of the papers and the journals changed the cutoff for success from 50% to 40%. Because the average weight loss for a band was about 45%, so the majority of band patients were, by the old definition, were failing. But going back to using 50% as success, about 80% or more of patients will keep the weight off the rest of their life with the bypass. Sleeve gastrectomy is an interesting question. People always say, well, what's about sleeve? I showed you, sleeve really only got popular in about 2008. So the best data I've seen out there is by a guy named Michel Gagne. It's about 4-year data. And in 4 years, they keep the weight off. They lose the weight and they keep it off. We do not have 10-year data. So we don't know, like with the vertical banded gastroplasty or the lap band, both those operations got very popular within 5 years. The reason they fell out of favor 10 years down the road was that long-term the weight wasn't coming off. Although again, the lap band, it never really came off for some. But either way, 10 years later, it wasn't considered a good operation. So sleeve gastrectomy, great 4-year data, #1 operation in the world actually, as well as the United States. But we don't know if the 10-year data yet. But at this point, it looks promising. And one of the reasons it may stand the test of time is, again, it's not purely restrictive. Removing that part of your stomach has some effect on your glucose metabolism and other good metabolic effects, which the VBG and the band probably didn't have. So we think that maybe that long term that the sleeve may stand the test of time. As far as evaluating patients, what we typically do to evaluate patients, people always want to know, well, how do you actually get through a process like this? I mentioned earlier that we do an informational seminar every month at the hospital. In an auditorium, go through a slide presentation, hand out booklets, and I tell people at the end if they want to, proceed, obviously you have to come to the office for a surgical evaluation and meet myself or Dr. Castro, meet our nurse practitioner, and basically we take your history and physical, we calculate your BMI, figure out how many pounds you're overweight, or what your excess weight is, and then we finally talk about, what your goals might be, what operation the patient might want. Again, most choose sleeve, some choose bypass. And then at that point we figure out what other testing you have to do. Everybody has to do a medical evaluation. In New York, interestingly, most insurance companies require all these patients to go for 6 months of counseling first. Not because, again, it's my shot at the insurance companies, not because it medically helps them, it's just it delays things 6 months. And studies have shown that about 30% of people who have to go do 6 months of counseling won't follow through with it. So that's 30% less surgery they have to pay for. So I don't want that, but I commonly do send them back. If I saw a patient with Dr. Bright's, I might say, go back to Dr. Bright and I want you to see a cardiologist and pulmonologist and get an endoscopy before surgery. That's very common. A lot of surgeons do that routinely with every patient. They all have to get cardiac clearance. They all have to get a pulmonary clearance. They all have to get an endoscopy. I'm a little bit more selective, but if you're diabetic, I'm definitely going to want cardiac clearance and say, let your doctor, have your doctor send you to a cardiologist. If you have asthma or you smoke, you have to get you off cigarettes. I usually scope most of my patients for sleeve or bypass. I want to make sure there's nothing in the stomach before we staple it. That's abnormal. So, although I'm not 100% like some surgeons, majority of my patients do see a cardiologist for clearance, pulmonologist for clearance, get an upper endoscopy, do 6 months of counseling with their physician. They have to go every month and be told to lose weight through diet and exercise and have their weight recorded. And then the doctor has to write a letter at the end of 6 months. Everybody has to do a nutrition evaluation preoperatively, and everybody has to do a psychiatric evaluation. People always say, well, why this? One, I think it's a major change in people's lives. It's worth talking about. They also want to make sure you understand what you're getting into. And lastly, it's also an insurance requirement. Insurance requires nutrition, psych, 6-month letter, and a surgical evaluation. And then these I want just from a medical, perspective to make sure the patient's safe enough to have surgery. Last thing, what does the future hold for obesity surgery or treating weight loss medically, or surgically actually? Interestingly, the picture didn't come out very well, but gastric balloons is like the hottest thing right now, but not in the United States. This is not available in the United States. Basically what it is they endoscopically put in your stomach a balloon with a tube on it. They start filling the balloon up with saline, and then the balloon fills up, and it gets about half a liter. Think about a half a liter soda bottle. A half a liter volume in that balloon. And they have a way to disconnect the tubing, pull it out of your mouth, and you're left with that balloon in your stomach. Again, it looks kind of like this, although my image came out blurry on the big screen. And what the thought is that it's going to make you, more full. Have less room in your stomach, rather than cutting out 70% of your stomach. You lose a half a liter of your stomach in volume because of the balloon. Weight loss is fairly good. There's a couple issues with it. One, the balloon can pop. So they actually have, I do my thought about this. They have blue dye in the balloon. So then if it pops, you'll pee green. So you'll know, you know when it pops, because if you pee green, the yellow urine and the blue dye in your urine turns green. So when your urine turns green, you can call up your doctor and say, I think my balloon popped. The problem with the popping balloon, though, is that it's fairly bulky. So people have gotten intestinal obstructions. because what happens is if the balloon passes out the stomach and out into your intestines, it's got to navigate, a good number, 10 feet of intestines and get into your colon. And once it gets to your colon's pretty big. But if it can't get through your intestines, or let's say you had previous belly surgery and you have some scar tissue in your belly, your bowels are a little kinked up a little bit, that might not make it through your intestines. So people have needed operations for blockages from the balloon. So that's why it's done in other countries. Europe and Mexico, actually, I know both have it. The FDA has not approved intragastric balloons in the United States because of these complications. Although I was just reading this morning, that there's some talk that maybe in the next year or two, the FDA, they may be able to get it through FDA approval. It's the same company that made lap band, actually. So they're trying to get this through the market. And it's interesting when I go to bariatric surgery meetings. They'll show like the lap band, but they'll also show the balloon. There's always a little placard next to it that says "Not approved in the United States." One of the really, and so the problem with this is that's really not a great option, long term. So people always joke, it's like, I'm going to go to my high school reunion, and I'll get this put into my high school reunion, and because you can't leave the balloon in there forever. And once the balloon is out, you're the same as you were before, so you're going to gain the weight back. So for a long-term solution, it's not great. I really don't think it should even be an option for the morbidly obese. Maybe that, again, the long-term data concerns me only in the sense that, once that balloon is out, you're going to gain the weight back. Where it may play a role as far as what I do as a bariatric surgeon is if I get that 400-pound person or that 500-pound person, that's, the average person having surgery is 300 pounds with a BMI in the high 40s in a woman. Men are hard to operate on because they put all their weight in the abdomen. If I have a 450, 500-pound man, maybe I put a balloon in him first, and get him down, to a much lower weight, and get the balloon out and then do a sleeve or a bypass on him at a much safer weight. So I see that as a role in the United States for treating the 450, 500, 600-pound person to get them down to a weight where they're more safer to have a obesity operation. But I think for the average person, to put a balloon in somebody that's only going to be temporizing and eventually has the risk of bowel obstruction, it's probably not going to work well, or even shouldn't become that popular, even if the FDA does approve it in the next year or two. So in general, in conclusion, obesity rates are skyrocketing. I mean, 1 in 3. I think it's going to be a lot higher than that, soon. I think by 2020 it's going to be 40%, not 33% of Americans are obese. The thing I meant to touch on in this talk was childhood obesity is through the roof, and that's the problem. In the same slides, I used to have a slide that showed that in the 70s, childhood obesity was 3%. And I like your picture of the you're totally right. I think a lot of people looked at the kid now in the original Willy Wonka and be like, he's a little heavy. The perceptions have changed a lot. And back in the 70s, it was about 3%. Obesity rates right now in the United States in children is about 16%. It's a 4-fold increase. In New York City, it's 20%. So, the issue with that is that a lot of what I do is for that obese adult who can't get the weight off. The key is never to become an obese adult. So that's why childhood obesity is such a big deal. You really got, once you're an obese adult and you're more than 100 pounds overweight and you've tried a bunch of diets and you haven't gotten off, unfortunately the success rates aren't great for that population. That's why they come to me. But the key is never to become obese in the first place, and that key is never to let the child become obese, because obese teenager, 80% will become obese adults. Children, obese child, 50-50. Right there you got a 50-50 chance you're going to be an obese adult and have to deal with all the complications. It's now the number 2 cause of leading death in the United States after cigarettes. That's preventable. I would put that there. The odds of successful weight loss in an adult who's earnestly tried is probably, abysmal was from that statement I showed you. The NIH actually said it's abysmal. It's probably in the order of about 1%. Again, we're not talking about somebody who needs to lose 30 pounds. We're talking about patients that I see that are, need to lose at least 100 on average. The lap bands really fall out of favor in most centers, and it's not considered a really good option. Lap sleeve is the #1 operation right now in the United States and in the world. I think because of its safety profile, that's a lot better than a laparoscopic bypass, and a weight loss that's a lot better than a lap band, basically. And then the intragastric balloon, not approved. Although people are talking about that it might, I think, in the next year or so, I think ultimately, I'd like to think that this probably won't get approved, because I think that the risk of bowel obstruction is way too great for this. I think that's it. Yeah, Dr. Brady.
Thank you so much.
Well, thank you for having me.
I'll take questions now, if any down.
Right here, and
Set them up here. Okay. I'll start off with